I deal with arthritis, and as you heard, mostly with lupus. And I deal with a lot of systemic disease, and that's why I deal with everybody who's on the program today. Arthritis is more than just some ache or pain that you're going to get when you get older. And what I'm going to try to convince you is to tell you about the spectrum and burden of rheumatologic diseases, because they preferentially affect women, so they affect the entire life cycle or lifespan of women. We usually take care of women or older adolescents at about age 18, so I don't really do pediatrics. But I can tell you the transition from pediatrics to adult care can be quite tricky. You can imagine that that's a difficult time in a person's life, and you can imagine going away to college and meeting a new rheumatologist who's an adult rheumatologist. So there are a lot of other things that we do in addition to taking care of their disease. And then I'm going to tell you about two programs that we have here at Northwestern. My bias, which is lupus, but I'll also tell you about scleroderma, because these are two of the most challenging diseases that we have, and they preferentially affect women. So just to give you an idea of what the burden of having an arthritis or muscle disease, joint disease, or bone disease has, there are over 100 different forms of these types of rheumatic diseases, and they affect 50 million Americans. So, you know, cancer gets a lot of play, heart disease gets a lot of play, but arthritis should also be up there. And I'm not going to show you any mortality data, but once you have some arthritis condition, you're more likely to have a disability, and once you have one comorbidity, you have more, and it can affect your mortality. Rheumatic diseases are important because they can destroy the joint, and because they can be systemic, they can destroy other organs. They can cause severe pain, disability, and as I mentioned, death. And they're quite expensive to the healthcare costs of this country. Latest figures show that they would be about almost $130 billion in healthcare costs in the US. And if you compare that to cancer, it beats cancer. So what is this burden about rheumatic disease in women? Well, 1 in 12 women will develop a rheumatic disease in her lifetime, whereas 1 in 20 men will develop a rheumatic disease. 75% of over 1 million women who are American adults get rheumatoid arthritis, and they're all women. Women are 2 to 3 times more likely to get rheumatoid arthritis compared to men. I'll show you the scleroderma slides in a moment. That's 4 times, and lupus affects women 10 times more than men. And these diseases affect women at a critical part in their life. Rheumatoid arthritis gets you between 35 and 50. Lupus gets you mostly between 15 and 44. And scleroderma spans both of these from about 35 to even up to 65. And what frequently is not appreciated is that minority populations are preferentially affected by these diseases. So these are national health statistics. This is from the Health Interview Survey. It's a complicated slide. I only want you to look at 2 lines. What we are looking at is doctor-diagnosed arthritis, and then also arthritis attributable activity limitation. So that means they have some limitation in their activities of daily living, and if they have arthritis, it's even more. So if you look at the bolded top line, you can see that 20% of the US population has a doctor diagnosis of any type of rheumatoid arthritis. 10% will have some activity limitation, and if you have both, that's 40%. And then I want you to concentrate on the box that's now highlighted by red. Women trump men in every one of these categories. 50% of women in this survey had arthritis diagnosed by their doctor. 11% had a limitation, and 44% of them had their arthritis and their limitation together really limit what they can do. So here at Northwestern, we have multiple programs that try to deal with all the various aspects of arthritis, musculoskeletal problems that any patient can encounter. We're one of several centers in the US that's funded by the NIH as a multipurpose arthritis musculoskeletal diseases center, and we have multidisciplinary teams that diagnose and treat all of these conditions, And these are the various areas where we have our expertise. And I apologize for my bias listing lupus first. And I'm going to tell you about scleroderma. I don't have slides on the rest of the things that are listed there in the interest of time, but I do have some more specific information, not only about lupus and scleroderma, but several other conditions in the workshop, and we can decide how we want to use that detailed information. And because all of these diseases affect women, one of the areas that I'm interested in is how do you manage these rheumatic diseases when women become pregnant or are thinking about getting pregnant, and we can discuss that in the workshop. So this is our lupus research program at Northwestern. And what I wanted to give you an idea is what is lupus like? So this slide shows you lupus on the outside and lupus on the inside. So lupus on the outside, it's a systemic disease, so it can affect your skin. So you see various rashes, you see hair loss. You can see that it affects the mucosal surface, and that's an ulcer on the hard palate on the roof of your mouth. It can cause arthritis. And then we can measure certain things in the laboratory. So on the lower left, you see the anti-nuclear antibody, an immunofluorescence test. It can affect the heart or the lungs, causing fluid around either of those organs, causing very significant pain and dysfunction of those organs, just as examples of what can happen in that situation. And the pathology slide there on the lower right is an effect of the kidney, which is the most common bad thing that can happen. What I can't show you on this slide is actually what becomes a major issue when dealing with lupus patients, and that's what I call the lupus intangibles. They have pain, they're tired, they can't think straight, and they're depressed. There are some ways that we can measure those patient-reported outcomes. There are some validated scores, but when we take care of patients, it's not just the things that I can see, it's not just the things that I can measure, but it's what they tell me and how they feel. This disease has an impact on physical and mental health. So I told you that these diseases preferentially affect women. These are very recent figures from 2014. This was a collaboration between the CDC and state public health organizations and the Indian Health Service. And they targeted 3 sites: Atlanta, Georgia, Detroit, Michigan, and Oklahoma, Alaska, and Arizona. What I have highlighted for you in red shows the preferential occurrence of lupus in women, minority women, and also a group that frequently is not reported are the American Indian and Native Alaskans. What I can't show you right now, because that data is still in progress, is the impact of this disease or the occurrence of this disease in Hispanics. Those are ongoing studies going on in New York City and in San Francisco, and those results have yet to be published. So you can see 9 to 1, in terms of men affecting women. So this is these are the objectives of our lupus program here at Northwestern. We want to develop a clinical research program to understand and improve the outcomes of our patients with lupus. We want to provide outstanding clinical care and coordinated care and offer them new treatment options. We want to train the next generation of young investigators to continue the drive to cure this disease. We collaborate with basic scientists to understand the causes of lupus and to discover new treatments. And the newest aspect of our program is we're partnering with community organizations to reduce the health disparities in lupus. So these are some of our active programs. We assess risks of comorbid conditions, osteoporosis, cardiovascular disease, in our study called Solvable, which is the study of lupus vascular and bone long-term endpoints. And one of the things that we've been able to highlight is you usually think about heart disease in someone who is older, but young women with lupus get heart attacks. So a young woman with lupus who presents with chest pain needs a significant evaluation because it can be missed and they die if they're in their 20s or 30s. We also collaborate nationally and internationally to study genetic risk factors, further expand our work in cardiovascular disease. We're one of the major groups that looks at the risk of cancer in lupus. We look at renal outcomes, neuropsychiatric outcomes, and the tremendous economic impact of having lupus, especially if you're young and in the productive years of your life. We look at activity in lupus, and that's our ALTER study to try to energize and renew, because I told you that a lot of the patients are fatigued. And we're adding a new element to it to look at nutrition, because many patients ask me, well, what should I eat to make this thing go away? And I have to tell you, there's like nothing in the literature that really helps me with a specific recommendation for a lupus diet. Our REACH program, which is the roadmap for education and access to care for the Chicago Hispanic lupus patients, is our activity to try to help reduce health disparities. And this has evolved into what we call the Monarcas program. And Monarca is the Spanish word for butterfly, and these is the name that our community workers gave themselves as a group when they go out in the community to increase lupus awareness in the community and help act as navigators so these patients can get care. SABLE is a phase 4 long-term monitoring study, which is looking at the long-term outcomes of the only biologic medication that was approved for lupus in 2011. All of the other drugs that are officially approved for lupus were approved in about 1955, and that includes corticosteroids, an anti-malarial called Plaquenil, or hydroxychloroquine, and aspirin. Everything else that we use is off-label. And the other thing that we do as part of our program is that we help to design, monitor, and perform clinical trials and come up with these innovative therapies. So these are our lupus team members. This is from our community outreach program about a year and a half ago. You can see that we are a very diverse group of individuals, and some of my research lead coordinators have gone on their own and gotten advanced degrees and working in lupus. I'm going to just talk briefly about the scleroderma program, and all of the slides that I'm showing you are courtesy of Dr. John Varga, who is the director of that program, and those are some members of his team. So I showed you the inside and outside of lupus. Here's the inside and outside of scleroderma and what it looks like, and they too have those intangibles or things that they feel that are very difficult to measure. So what you can see, you see a lot of dark, white or bright white spots. Those are calcium deposits in the skin. You see that pathology slide next to the legs. That is an artery that's blocked in the kidney so that the kidney doesn't function, and it's called renal crisis. As you look all the way over to the far right on the top, those are called telangiectasias. This disease, if you see the x-ray, now we're in the middle line of, on the left, that's a lung that's scarred. And you see the gentleman in the middle of that, his skin is like cement. He can't move. It's tight and it's hide-bound, and he can really only do this. If you see on the lower left, you see some fingers. That means his hands are like this, and he cannot straighten them. And I have several patients that are like this, and this woman plays the piano like that. So people can be very resourceful. In the middle, you see some white fingers with some white blanching. That's called Raynaud's, and that can be very painful. And if it's painful enough, then they'll actually lose parts of their fingertips and become ischemic. And they also have swallowing difficulties, and that's an esophagus that's just wide open, and the food is just stuck there. So scleroderma also has a female prominence, a little bit older age range in terms of affecting individuals, but if it occurs early, it's more severe again in minorities, again, particularly in African American patients. The composite of slides I showed you just previously show you the effects of the skin, the lung, the kidneys, the heart, the GI tract, the joints, and the tendons. And the problem here is that the problem with the vasculature, so that the blood vessels get blocked, or the surrounding tissues become fibrotic and scar. And that's why they can't move, or that's why the various organs don't function properly. And just like lupus, there's a very variable presentation. And it's very unpredictable. Like, some people will get one spectrum of disease, other will get another one, and it can happen over time. And it can be very challenging to make this diagnosis. And it's not unusual for patients to suffer with something for several years before somebody gets it right. As opposed to lupus, where we have 4 drugs that are approved, there is no drug that it's specifically approved for scleroderma. We just have much better supportive care than when I started as a fellow a number of years ago. This is the history of the development of the scleroderma program. First, they had a lab, then they added clinic, then they added genetic studies, and they've received funding from various organizations so that now they're up to 1,000 patients. So it's a quite robust laboratory-based and clinical-based program, and also testing medications, because I told you that there's nothing that's approved for it that can definitely change the tempo of disease. These are their targets of what they're trying to work on: novel targets, genetic risk, innovative clinical trials, and developing the new therapies. This is one of the advances that's been made in scleroderma, and what they're trying to do is they biopsy skin, and then they do what they call a molecular analysis of the skin cells and how the genes are functioning in terms of a microarray, and then they see how patients respond to a drug, and in this case, it's mycophenolate mofetil. And what they've been able to show is that patients who have a genetic signature that looks more inflammatory, they might be the patients who would respond. So this would be a very important sort of pre-screening. If you were going to do a study to see if this drug worked, you would give it to somebody who had an inflammatory pattern, because you would predict that it would work better than someone who's already fibrosed and scarred, where an immunosuppressive drug wouldn't do anything because there are no cells left to affect. They also participate in some consortiums for clinical trials, and this is their big group. And this includes the laboratory personnel as well as the clinicians. And the lower right-hand smiling guy is John Varga, who shared his slides with me. And this is just our summary of just a brief overview of what we can do for patients who have these diseases, which occur in younger people. Don't think of arthritis as only something in an old person, and that we can hopefully make an impact in the future. Thank you.